Talk today is Jason Katz. Everyone in this field knows him very well. He's an associate professor of medicine and director of cardiovascular critical care at Duke University Health System. He's also the co-director of the Duke Mechanical Circulatory Support Program. He will be talking to us about hemodynamic phenotypes of cardiogenic shock. Dr. Katz.
Good morning, everyone. Thanks for coming so early. It's nice to be back here after a 4-year absence. I was here for the very first Houston Shock Symposium, which was excellent, and really happy to be back. I joked with Nir yesterday that in 4 years nothing had changed with the cardiogenic shock guidelines, but I think already it's been impressive to see how much the field of cardiogenic shock certainly has evolved over the last 4 years. We've all evolved. 4 years ago, I wasn't wearing glasses to see these slides, so I have 8 minutes to talk about hemodynamic phenotypes, so enough joking around. I'll go ahead and move. I have research support that I received from Abbott Corporation. So I'm a simple guy. I like to present things quite simply, and this is how I'd really like for us to understand cardiogenic shock and like to be able to manage it, right? Cardiogenic shock is simple. It's a low cardiac output state leading to end organ hypoperfusion, tissue hypoxemia, and its sequelae. And it should be simple, right? You'll know it when you see it. And again, this was me a little over a decade ago presenting to fellows at the University of North Carolina, where I was a simple baby attending doctor. And I try to make cardiogenic shock nice and simple as well, right? There was one hemodynamic phenotype that I thought represented cardiogenic shock, one phenotype which represented distributive shock, one phenotype which represented hypovolemic shock. But it turns out I was completely wrong, and age has clarified that a bit. Not all cardiogenic shock is created equal. You can get 10 patients coming to your cardiac ICU with cardiogenic shock, and they may all be very different with baseline characteristics, illness severity, different sky shock presentations, and different hemodynamic profiles. And we alluded to this a little bit in a AHA scientific statement that we published in 2017, where we sort of emphasized and reintroduced this concept of understanding and managing cardiogenic shock. We clarified that there are probably multiple phenotypic and hemodynamic presentations for cardiogenic shock, and to be sure, there wasn't a lot of data underscoring this 4x4 table. In fact, we extrapolated it largely from the acute heart failure literature, but did want to sort of get across the idea that not all cardiogenic shock is created the same, that there are patients that present with sort of classic cardiogenic shock where their cardiac filling pressures are elevated and their systemic vascular resistance is elevated, and they present in sort of a classic cold and wet phenomenon, but acknowledging also at the same time that there are other ways patients present, including relatively euvolemic with normal cardiac filling pressures, and to be sure, a sort of vasodilatory component to cardiogenic shock, and alluded to the seminal shock trial and registry in which about a quarter of patients presented with cardiogenic shock but a low systemic vascular resistance. At the time, a sort of allusion to a sepsis-like phenotype for patients with cardiogenic shock. I got a little scared when I got sent this topic, and I curled up in the corner in the fetal position because my kids had just gone through genetics and were trying to have me answer questions about Punnett squares, et cetera. So I'm going to demystify phenotypes for you here because I needed to do that for myself. And if we're going to talk about phenotypes, and again, to be sure, we're talking about hemodynamic phenotypes alone in this talk, but there'll be other phenotypes we'll discuss. It is basically a set of observable characteristics of an individual. And in here, we'll talk about some of those different individual characteristics from a hemodynamic standpoint. So why would it be helpful for us to profile cardiogenic shock patients by phenotypes, in this case, hemodynamic phenotypes? Well, it's quite possible, and I'm sure you've seen this anecdotally in your own experiences, that patients with different phenotypes of cardiogenic shock may respond variably or differently to the available pharmacologic and mechanical support strategies that we have in our armamentarium. It's also possible that individual patient groups, perhaps separated by phenotypic presentations, may have variable risk-benefit profiles, particularly when applying different therapeutic strategies. And I think if you look at the clinical trials that have been conducted so far, I think we could probably all agree that there's a likelihood that many are confounded by marked heterogeneity in the patients that we include. And in fact, you've heard this. I think there are a couple of themes that resonated yesterday. One theme was apples to oranges. And again, I'm going to highlight that because there's there's a likelihood that the failure of the clinical trials to date that really have thus far shown no demonstrable improvement in outcomes for certain therapeutic modalities, particularly mechanical circulatory support modalities, may be doomed to ongoing failure if we don't figure out how to compare apples to apples instead of apples to oranges, or in many cases, apples to Yugos. You know, when I teach in the cardiac ICU or on the mechanical circulatory support service, I oftentimes emphasize to the fellows, to the residents, to the advanced practice providers, to my colleagues, to try to leverage physiology, or in many cases pathophysiology, to drive or guide therapy. This is just looking at the different hemodynamic profiles of our pharmacologic agents, right? We have an alphabet soup of therapies, in this case pharmacologic therapies, available to us, and there may be many things that drive our initial decision making, but if we're privy to invasive hemodynamic information, we should try to leverage that invasive hemodynamic information to match it to an appropriate pharmacologic therapy. So if the patient is in classic cardiogenic shock with high systemic vascular resistance, maybe you want to leverage an agent that increases contractility but also vasodilates. If, however, you have that 1/4 of patients that have a low systemic vascular resistance, a mixed shock picture, adding a vasodilator may not be appropriate for that patient. In fact, you may want to use an agent that increases systemic vascular resistance, plus or minus increasing contractility. So I think there's value in understanding the hemodynamics, particularly if you have it. You've heard this before, you'll hear this again throughout these discussions today and tomorrow, that there's minimal hemodynamic data and qualifiers that have thus far been present as inclusion criteria or exclusion criteria in our contemporary cardiogenic shock trials. This just looks at the seminal shock trial, the IABP shock 2 trial, and at the time the ESC heart failure guidelines. And again, part of that's due to the fact, and you may not know this, but we put the PA catheter to rest years ago. Partly that was due to the fact that in heterogeneous critical care populations, the use of a PA catheter did not demonstrably change outcomes. Increased risk, but didn't demonstrably change outcomes. And then we said, here's the problem. You're doing this in heterogeneous non-cardiac critical care populations. Give it to us, the cardiologist, the heart failure cardiologist, and we'll show you how valuable the PA catheter is. And then, of course, the ESCAPE trial came out, and we have sort of basically superimposed survival curves here. Again, not showing a demonstrable benefit in the use of PA catheter for routine therapy in an acute heart failure population. And so the PA catheter was put to rest in the mid-2000s, but there's been a resurgence for sure. Largely driven by shock and the use of temporary mechanical circulatory support strategies that totally changed the hemodynamic and metabolic profiles of these patients. We tried to phenotype before. This looks at a non-cardiac population. There's been evidence that we can phenotype through cluster techniques, multidimensional cluster techniques, to different phenotypes of sepsis. We can identify these sepsis patients who have differential immune responses and differential outcomes really early when they come to the emergency department. The question is, now that we can do that, what do we do about it? Thus far, not been privy to any clinical trials that suggested that improved outcomes. So somehow this forwarded to the last slide. Nice. I get how this works. So what I was going to say is I was going to show you something that was really provocative, or at least I thought was provocative when I put together this talk, and that was that there were this cluster demonstration of identifying hemodynamic phenotypes from the cardiogenic shock working group. I was going to suggest it was provocative, but I'll be now the fourth talk that would have shown it. But so you guys have seen those slides. You don't need to see mine at all. But there's value in potentially clustering patients by hemodynamic profiles and presentations. So I'll conclude with the following. Patients with cardiogenic shock are not all the same. They present with a variety of hemodynamic presentations and a variety of other presentations that would allow us to phenotype these patients. It's possible that phenotyping these patients at presentation may help us identify the most optimal and earliest therapies that will improve outcomes and help us also to overcome the heterogeneity that is currently undermining clinical trials. Invasive hemodynamic assessment, I think we'll all agree, is pretty crucial for cardiogenic shock management. Congestion may matter. We've known this since the ESCAPE trial, and we know it even more so now. We certainly need more data to understand exactly how to leverage invasive hemodynamic information. You've heard this before also. Cardiac arrest is probably a completely different beast, so we should not necessarily lump those together. And then when you think about profiling, whether it's be for clinical trials or for clinical care, you've got to sort of balance complexity with practicality, right? We can involve a number of combinations of things, etiologies, cardiomyopathy characteristics, patient characteristics, hemodynamics, to create the most optimal phenotypes that really sort of narrow the different populations. But at the same time, that becomes very unwieldy and perhaps completely impractical to use from a clinical standpoint. So I will stop there. It won't even allow me to advance to the thank you, but I'll thank you for doing this. That's pretty good, Marwin.
Thanks, Jason. Thank you. That was really great. I think a lot of the things that you touched on really we've already talked about yesterday. I mean, we really talked about this issue of profiling in one way or another. It's not only maybe about the hemodynamics, it's maybe about end organ function, this metabolic, the hemometabolic. And I think it's clear that I think we kind of, I think, came to some kind of a consensus, I don't know if I can say that one of the challenges with the here, you got this slide up now.
You got your slide.
One of the, this is a fantastic slide. Is it projecting to the audience? This is really a key slide, I think, that maybe you want to explain, but I think that we kind of came to a consensus about the concern about randomized trials enrolling heterogeneous patient populations, and the fact that patients respond differently to different therapies. I think you touched on all these things.
Yeah, I think it's tough. If you can advance like one or two more, there's some amazing animation. Oh yeah, there it is. I think that's absolutely true. And if you look at the current clinical trials, or the ones that have been conducted thus far, I mean, you could make a case that if you're not careful, you're including patients that don't have cardiac disease or cardiogenic shock at all. Some are so sort of broad in terms of their entrance criteria, right? They have to have a low blood pressure for a certain amount of time despite fluid initiation, and they have evidence of end organ dysfunction. Well, I can say that for most cases of septic or distributive shock, a number of cases of hypovolemic or hemorrhagic shock. So there's got to be a way that we sort of can tease those out, either prospectively or retrospectively among those. I think we all, I bet, with a raise of hands, you could understand that. I think we're all sort of under, on the Swan-Ganz bandwagon, that we now realize the value of invasive hemodynamics, although you can go overboard with that as well. I oftentimes tell the trainees, like, use the Swan-Ganz information as a stock market, right? Follow the trends, be prepared for the crash, but don't make subtle, significant decisions based on moment-to-moment changes. But to get to your question, I think yes, I think there's going to be a real need to sort of figure out how these patients are different, and to somehow pair therapies with those individual patients. And this was a great sort of provocative first step in trying to do that. And I think future studies are going to have to really incorporate and collect, someone had mentioned this before, collect really granular data, as much granular data as we can, to get to the reality of what we're presenting.
Yeah.
Jason, about phenotypes, I believe that age and etiologies are really relevant, because in my view the juvenile cardiogenic shock is another history, and you can associate it. For instance, I'm an passionate of myocarditis, but myocarditis is a completely different phenotype, and that is just an example as we face cardiogenic shock, thinking about etiology and specificity. And even within myocarditis, we have seen with the COVID some good examples of delayed myocarditis due to multi-inflammatory system response after COVID. That is a very interesting phenotype of a mixed model of cardiogenic shock. I would like your comment about that.
I think I'll make a couple comments here. Again, one, I was sort of tasked with just discussing hemodynamic phenotyping, but I completely agree with you that there's plenty just as important, if not more important, than the hemodynamic presentations of these patients, and age is important, etiology of the heart failure is important, the acuity. We sort of bemoan the fact that most of these trials and observational studies are in the acute MI cardiogenic shock patients, and then we scream from the top of our lungs, but that's not the patient population we're seeing most commonly in the ICUs. In fact, it's the patients, regardless of the etiology, that are not presenting with acute coronary syndromes. But the nice thing about acute MI shock is that there's a clear pathophysiologic target for revascularization, a clear pathophysiologic insult that leads to the decompensation. It becomes much more complicated with all these other types of patients. So yes, I think understanding things not just from a hemodynamic standpoint, but from an etiology standpoint, from a patient characteristic standpoint. We've talked about this from a metabolic standpoint. The patient with acute liver injury in the throes of cardiogenic shock is very different than the patient that doesn't have liver injury. The patient with unrelenting lactic acidosis or acidosis for whatever reason can be very, very challenging to manage, and oftentimes changes their hemodynamic presentation, right? They may present with classic cardiogenic shock, but due to the unrelenting influence of acidosis, they may become a mixed shock picture very, very quickly. So that trajectory is important to acknowledge.
Nir?
So, Jason, I'm looking at it, and this is something that we repeated this slide, I think, 3 times already in this meeting, and it's very good, maybe 4.
Yeah.
Is it phenotype or is it timeline? Meaning, is what we are seeing here is actually a deterioration of cardiogenic shock, and what we are capturing it is in a different type time. And when we speak about phenotype, and that's the reason I think Enrico's comment is very appropriate about the definition about etiology as a phenotype, rather than this is actually the progression of cardiogenic shock. You start uncongested, you move to cardiorenal, and then all break loose and everything is down.
Yeah, and I think that's the challenge of these observational or retrospective studies. I think that absolutely can be confounding the phenotyping of these patients. I remember, I'm going to share a quick story with the audience. So the first time I met Ariel was at the ISHLT meeting. I don't know if you remember this, but I was giving a talk on hemolysis in VAD patients, and you were the audience, and you asked me a question, and I had stayed out a little bit long the night before and was kind of under the weather the next day, and you asked me a question about how to do something, and I said, and I can't believe I said this, but I said, Nir, that's for smart people like you to figure out. That's going to be for smart people like all of us to figure out. I mean, I think the timing, there's a trajectory of patient sequelae of shock that we're seeing, that we see every single day, and understanding that and the timing and acknowledging the fact that these people change under therapies is really important, right? That's part of the problem that I've had with most cardiogenic shock trials, right? You have the upfront therapy, and then you have the outcomes, and there's a lot of variability in what happens in between. What happens when those patients are in the ICU, how they're managed, how they're observed, what therapies are delivered. We're not even talking about support for other organ systems. Lots of stuff is happening that confounds their care and their presentation. We have to be able to figure out how to do that.
Thank you. There's a question from the audience.
Oh.
Hey.
Not smart, but I'll take a stab at what Nir actually asked, which was, is it timeline or is it phenotype? Mm-hmm. And it's my charge this morning to speak about molecular biology. So I would say it's both, because what I think is true is that we really know that the way that the heart or the body behaves at minute 1 versus minute 50 versus a year later in terms of your molecular signaling changes. So in fact, the phenotype and the genotype and the expression of that gene does change with time. And the way to get back to what otherwise would be normal is not to have a reverse pathway, because in fact it's probably going to be some makeshift mechanism which gets you back to something that phenotypically looks normal but probably wasn't ever normal again.
Completely agree.
Perfect. For the sake of time, thank you so much, Dr. Katz. Thank you.